It always seems extraordinary to me that one of the major ingredients of our diet, which is cereal and grains, gets such a poor press in the adult gastrointestinal world. So here we have irritable bowel syndrome, diverticular disease and colorectal cancer, and we can't agree on what is the cause. I know there have been lots of studies with irritable bowel and intervention with fibre, and they've been here and there, but no convincing evidence that fibre intervention in later life makes a difference. Also, the evidence that lack of fibre in your childhood contributes to diverticular disease has been somewhat unconvincing. And in terms of colorectal cancer, I happen to believe that fibre and starch is the most important ingredient, but that also gets subjugated to saturated fat and all the other things. So here we have the opportunity to talk about dietary fibre in children, which is where we should be talking about it, not 20 years later, and see if we can intervene and change their patterns of fibre eating, and more particularly check the outcome of what happens to these kids when we give them some fibre. So we're going to start this morning by welcoming Joanne Slavin, who's going to give us a global perspective about fibre. And Joanne, welcome.
Thanks, Dr. Boland. It's great to be here talking about fibre in kids. So what we're going to do, I'm going to talk first, Dr. Boland's going to talk, and then we'll have questions at the end. So hopefully if you have questions, we'd love to hear from you. So I give a lot of fibre talks, and probably people think, do they always have to be in Australia? Haven't I heard her before? So I think there needs to be more fibre people out there. So it seems like whenever people say we need a fibre person, my name comes up. So I'd love to encourage more people to work on fibre. It's an important area. I've worked in it for many years, and I think what happens is people just think there's nothing new. So unfortunately, that's where we're at. So we're trying to get people more interested in fibre. So whenever I'm out talking to consumers about fibre, the usual question is constipation in kids. So it's this constant question. People really want to know, why are my kids constipated, and can fibre do something for them? So I want to talk a little bit about just fibre recommendations for kids. We know that fibre intakes are low. So across all countries, when you look at fibre intakes, if you've been in this area a long time, you know that there are differences in methods, and numbers don't mean exactly. But in general, fibre intakes are about half what is recommended. And in the U.S., it's about 15. Other countries, about the same range. One of the big reasons is most fibre foods are really low in fibre. So if you talk to people, they say, I had an apple, so I'm good to go, or I had lettuce last night. But fruits and vegetables tend to be pretty low in fibre. So if you look at some of these recommendations to get 38 grams of fibre, try putting those diets together with fruits and vegetables. It's very difficult to do. So grain fibre is usually the biggest source of fibre in our diet, and an important one. In the N. Haynes data set in the U.S., if you look at what are the big contributors to fibre, it is white bread and white potatoes. And it's not that either of these are really high in fibre, it's just that's what people actually consume. There's a lot of interest in adding fibre into the diet. So I think obviously we want to keep pushing high fibre foods, getting people to eat more fibres, but a lot of interest in meeting consumers halfway and actually adding fibre into foods they're actually consuming. How do we come up with fibre recommendations? This is very difficult, and every country kind of comes up with a different way. But I'm going to talk about the U.S. and Canada. We have the dietary reference intakes. And what we have are adequate intakes. So rather than an RDA, fibre doesn't fit your typical nutrient. It's not like a vitamin or a mineral. So is it essential? It's on nutrition labels. It's essential in some ways. It's just not the usual thing. So what we have is an adequate intake. And if we look at the levels for men and women, they're based on 14 grams of fibre per 1,000 kcals. So they're actually calculated out based on that number. And why did we come up with that number? If you go in and look in the DRIs, that is the level in the prospective cohort studies that shows protection from cardiovascular disease. So that number comes right off 4 big prospective cohort studies. And at that level, you see protection from cardiovascular disease. Most of that fibre is cereal fibre. So we'll talk more about that as we go through here. There's no reason to set an upper level. So for the DRIs, there was interest, is there an upper level? And we know that humans can adapt to very high fiber intake. So there's no reason to have people worry that there's too much fiber in the diet. We're not there at all. These are the adequate intakes, and remember, these are just calculated based on this number. So 14 grams of fiber per 1,000 kcals in the diet. So what you do with, if you go in the DRIs, what they've done is figure out what are the calorie needs for a child age 1 to 3, and then they calculate it out and say 19 grams of fiber. Well, if you've ever looked at fiber intakes and fed a 1 to 3-year-old, you're like, that's pretty high. That's definitely too high, probably. And, you know, when people read that chapter, nobody said, well, is that exactly the right number? So that is the official adequate intake and based on this number. And as you can see, what happens as you go up the line, for older people, your adequate intakes are lower because their calorie needs are lower. And there really isn't good data that older people need less fiber than younger people. So there's a lot of controversy on these levels. If you look at labeling, typically recommendations are going to be in the 25 to 35 gram range across different countries. And for kids, going to be less than that. How about in Australia? Current adequate intake for fiber in Australian children is based on median intakes from the 1995 National Nutrition Survey. Now, as we go through this, you can see what's the perfect way of figuring this out. There is no perfect way to do this. So you're basically extrapolating from some data set because we don't have feeding studies in children. We don't have a lot of information to go from on that. It is lower compared to the U.S. and Canada. So we know that the Canadian recommendations are lower, and that constipation is also a big problem in Australia, not just in the U.S. and Canada. A lot of 17% is one survey that suggested that that was the incidence in Australian children. And where are we going to get fiber into the diet? Obviously, if we want to increase fiber, where is it going to be? One obvious thing is breakfast cereal, because a lot of kids do eat breakfast cereal, but most of those choices are not high fiber. So getting kids to eat breakfast cereal and then making sure those those cereal choices are actually high in fiber. I mentioned the nutrition facts in the U.S., 25 grams per day, and if you look around the world, a lot of labeling will be in that level. There's no reason that fiber should go down with age. You know, it really doesn't make sense about that. The recommendations for children have always been difficult to come up with, because you know what you'd say, well, if a baby starts out in breast milk, well, there's no fiber in breast milk, but actually there's a lot of oligosaccharides in breast milk. So since oligosaccharides now fit within fiber, breast milk has fiber. So trying to figure out what are the right levels for kids, some other older recommendations were the age plus 5 rule. So a 5-year-old child would need 10 grams of fiber. A 15-year-old child would need 20 grams of fiber, but most kids, school-age kids, are not getting those levels, even those lower levels. This is a review article that I did with Sybil Cron's, and we just published in Advances in Nutrition, and the review was called What Do We Know About Dietary Fiber Intake in Children and Health? Reviewed everything that was out there, and there's very little to go on. You know, it's a very common problem. People talk about constipation being a problem, but there's just aren't clinical studies. There's not much to go on. So there just aren't studies in children. Typically, we take adult studies and we extrapolate. And remember, constipation is not a fiber deficiency disease. It's one part of it, but a lot of other things are important. Regular meals, regular bowel habits, exercise, drug interactions, all of these need to be considered. So whenever we just say give more fiber, that's the important dietary piece, but lots of other pieces need to go into constipation relief. I mentioned there's no upper level for fiber. So even if you go too high, what happens? There could be gastrointestinal symptoms with certain fibers, but this is a direct quote out of the DRIs. Due to the bulky nature of fiber in foods, excess consumption is likely to be self-limiting. Very few people are we worried about too much fiber. It's usually not enough. We know fiber has effects throughout the digestive tract. And this is what gives us lots of opportunity to study fiber, because there's chewing, there's stomach effects, and if you just follow it through the digestive tract, thinking of what you're eating right now, if you're having white bread versus a really heavy whole grain bread, there's going to be more chewing, more digestive processing of a whole grain, high cereal fiber diet. Then it'll be more slowly emptied from the stomach. And there's changes in gut hormones throughout the digestive tract, changes in glucose, insulin, other hormones. And just most of the action really is in the large intestine. So fiber is something that escapes digestion and absorption in the upper digestive tract, but it does affect every part of the digestive tract. So when people say, what does fiber do? It does lots of things. And that's why different fibers are important, and hopefully the recommendation I'll get by the end to you that we want to get cereal fiber for sure into people's diets and kids' diets, but a variety of fibers is what we're going after. Okay, gut health. I was on the Dietary Guidelines Committee in the U.S., and everything in the U.S., and I think everywhere, is going to an evidence-based review. And a lot of things we think we know about, when you go to an evidence-based review, we just don't have great data. So here's the question: does dietary fiber increase stool weight and speed gastrointestinal transit? Everybody would say, well, we know the answer to that. It's true. But when you look at an evidence-based review, the DRIs actually went with cardiovascular disease protection because the data on gut health are not that clear. So the DRIs are based on epidemiological studies, 14 grams of fiber per 1,000 kcals. In 2008, there was an evidence-based review of fiber, and what was fiber and laxation was actually given a fairly low score, a grade 3, fair, and that's why you think, well, why would that be? Just because there aren't a lot of studies that actually show the effect of different fibers in the diet. So what is it? Gut health. I think when it's good, it's good. When it's not so good, people know it, but it's really hard to say, okay, what's our biomarker for gut health? Normal bowel functions, very subjective, so it's descriptive. Regular bowel movements, most people think, okay, if I have one bowel movement a day, then that's good. But if you look at the data for normal, do I have constipation or diarrhea, 3 bowel movements a day to 3 a week is considered normal. So if you can't get into that normal range, it's pretty tough. You know, you're going to be in tough shape. Desirable, most people, you know, it's just they have an idea of what it's going to be and they can describe it, but it's hard to measure in any way. Absence of symptoms. Symptoms typically people don't want. And just quality of life. A lot of the data is going into looking at quality of life because when digestive health isn't working, quality of life is very poor. So constipation, how easily and how regularly you have a bowel movement. Low fiber diet definitely linked. Lots of studies do show if I give fiber, especially wheat bran fiber, to you, I'm going to increase stool weight, and that's going to speed transit. Sedentary, sitting around. If you've worked in a nursing home, obviously you want to get people up to get things moving. Just ignoring. If you've ever toilet trained a toddler, you know, if they decide they're not going to go to the bathroom, then they're not going to go to the bathroom. You're going to have to wait. It's up to them. So, and the longer they resist that urge, you tend to have a constipation problem. Stress, laxatives, medications, lots of things affect it. This is some studies, exercise, little data on that. Smoking, coffee drinking. Some really interesting data just on habits that a lot of times when people give up smoking, sure, they miss the caffeine, but they say it really, I can't go to the bathroom. I give up coffee just because it's a habit. This last one, drugs obviously, but personality. This is a study where this was done up in the Grand Forks Nutrition Lab, and what you do there is you collect fecal samples on all your subjects over a long time period. So these people are on exactly the same diets. This is the closest you get to a human in a cage. They are in this lab, and they only eat the foods they're given. And what you find in those situations is that stool weight will vary by like 2-fold. So you think, how can that be? These people are eating exactly the same food, the exact same amount of fiber, and what they found was personality was a huge predictor of stool weight, that outgoing people actually had much larger stools. So just the psychological effects of this. So fiber cannot overrule everything. Now, if I told everybody, before you leave today, you have to give me a fecal sample, you'd say, you know, I really wish I hadn't taken that free breakfast. It wasn't worth it. Subjects will give blood, they'll give urine, but they don't like to give fecal samples. So we don't have large data sets on fecal samples. So unfortunately, in epidemiological studies, we don't have any of that data. And what's the standard? You know, where do you want to be? Stool weight, some people have said, 200 grams a day is this magic number. There really isn't any data that that's a magic number. Chemistry, the microbiota, a lot of interest in that. Frequency, the nice thing about frequency is people can collect that without collecting a fecal sample. And then I mentioned just quality of life being important. This was Dr. Cummings is actually trying to pull together the data that's out there in different stool weights. And what you can see, the king of stool weights is wheat bran. Wheat bran has the most effect per gram of fiber. So what they did is try to look at per gram of fiber, how much increase in stool weight do you get? And the reason wheat bran works as well as it does is a lot of it survives transit. A lot of fibers are completely broken down in the large intestine. And what you can see, things like inulin here, we did a study on inulin, and inulin is rapidly fermented, readily fermented, and none of it survives at the end. So why would you expect it to increase fecal size? Because why is there an increase in fecal size? Because you're generating bacteria, but also some fiber survives, and with that fiber, water goes out, stool weights increase. So tolerance. How much fiber can you eat? There's vegetarians that eat up to 80 grams a day. So we have a lot of, if we've got people at 15, there's a lot of space there. Some of the fibers that are out there, these novel fibers, 50 grams, 80 grams, you can get into people's diets and they're tolerated. Certain fibers are not very well tolerated. So if you were at the FODMAPs yesterday, probably things like inulin, sugar alcohols are the ones that are tolerated the least per gram. So if people are going to increase amounts of fiber, you want to get a variety of fiber and realize that things like cereal bran fibers are tolerated much better than some of these novel fibers. Fermentation, I just want to mention a lot of interest in fermentation, an area where there's a lot of disagreement on how to measure microbiota, but we know that this fermentation has a lot of physiological benefits. So increasing mineral absorption, the prebiotic effect, with the lowering of pH, some of the pathological bacteria actually get crowded out, and then just the short-chain fatty acid colonocyte nourishment. This is the big interest right now is differences in gut microbiota and obesity. So interesting area, a lot of inconsistent data. So I think it's like whenever people get interested, they think, oh, this is going to be easy, let's go, and then they go out and do studies. There are studies that show when people lose weight, you do see changes in the microbiota. So a big interest right now, and I think this is going to increase interest in fiber and giving people more fiber. So where is fiber? It's put in lots of foods. So, and this is good. I think, that we want people to eat more fruits, vegetables, legumes, grains. But as we tell people to eat less food, we're going to have to increase fiber in different foods. So higher fiber cereals, higher fiber other products can really help get more fiber into the diet. This is a list of some of the functional fibers that have been studied. And what you find in evidence-based medicine, at least in every country now, is to say, okay, you kind of have to show me the data. So if you have different fibers and what do different fibers do, things like inulin are very good prebiotics. Things like wheat bran are really good as far as laxation. Oat bran obviously lowers cholesterol. So different fibers do different things. And we can't expect every fiber to do everything. But more and more fibers are studied, and there's more clinical studies showing that they have these physiological benefits. So conclusions. If we look around, most people do not get enough fiber. And remember, fiber intakes are linked to food intakes. So as obesity is a problem in most countries, don't want to tell people to just eat more food. Eat more food to get more fiber. No, we want people to pick higher fiber foods. So this is true across the life cycle. I think in kids there's the least information, but for kids for sure, their fiber intakes are about half what they need to be, so we need to think of ways of getting kids fiber, things that they'll actually eat. Not all fibers are equally effective on measures of gut health. So if we look at the stool weight data, the cereal fibers are the most effective because they actually survive transit and actually form a stool. So there's advantages that. Tolerance does vary for different fibers, so as we're increasing fibers in the diet, we want to make sure that we're not adding fibers that are just easy to get into the diet that people like, but that aren't very well tolerated, and just clinical symptoms. Different fibers do different things, so we need to have more data on that. Prospective cohort epidemiological studies, clinical trials are needed to prove the effectiveness of isolated fibers on bowel function. A lot of countries are we need clinical trials before we can accept fibers as having important physiological facts. A lot of data already on cereal fiber, so it's a good thing, a good fiber to get into the diet. So appreciate your attention, and I want to introduce Dr. Bolin. He will be up next, and then when he's done, we will have time for questions. So his topic today is digestive health in Australian children. It's time for our dietary fiber recommendations to be challenged and increased. So.
Thanks, Joanne. The reason for talking about children is that it's much easier to say to a child, eat more fibre, than it is to an adult. Now, if I said to probably half the women in this room, eat more fibre, you'd say, I really can't eat any more fibre. I get too bloated and uncomfortable. And there's a very good reason for that, because your digestive system is more sensitive to the amount of gas that you produce, and that limits what you can eat. So you have to start in earlier life, and you have to give these kids a goal. And my goal when I speak to kids is you've got to produce a sausage every day. And it's not a chipolata, it's got to be a Kransky. So that's something to aim for. That's an objective thing that the kid can see. And you're not party to, but you've given them something. The Gut Foundation's been around for 30 years now, and we've always been interested in gastrointestinal research and education. And in the last decade, we've been much more interested in education in general and children in particular. So Joanne's mentioned the fibre gap, and the evidence for that predicted ideal intake is really very poor. The 1995 study in Australia, on which our recommendations are judged, presumed that there was normal laxation. And I think that's probably a very false presumption, certainly based on evidence that we've got today. So our intake is somewhere between 4 and 10 grams lower than is suggested in the US and Canada. And more recent study published this year shows that about 50% of children will have their recommended average intake of fibre reached. And I'm not sure about that. Certainly the studies that we've done would not support that conclusion. But all studies are a bit fragile and open to criticism. Everywhere, constipation is a problem. And I know that there was a figure of 17% for constipation in Australia in children. I think that is probably an underestimate, certainly on the studies that we've done that I'll tell you about. So 5 years ago, we looked at children around the age of 5 and looked at their fibre intake and gastrointestinal symptoms, and extraordinarily, 60% of the children were described by their parents as having pain, diarrhoea, or constipation, as did their parents. Now, normally we would expect about 10 to 15% of the population to have irritable bowel, which is pain, constipation, diarrhoea, same as these children have. So that's going to be an extraordinary explosion in irritable bowel if we can't change that pattern. And more recently, we've looked at older children between the ages of 8 and 12, and 40% have pain, constipation, or diarrhoea. 40% of all children will have gastrointestinal problems in the surveys that we did. We're over 1,000 children. And in that study, on the right-hand blue side, it represents the 41% who have those symptoms. And when you break that down, you will find that constipation affects about 44% of them, diarrhoea a smaller number, pain, or just an erratic bowel habit. When you ask women what do they understand about fibre, only about 1/3 do. And if their children has constipation, what do they give their children? They give them more water. Who do they ask for advice? Dietitians and GPs are very low on the list. They go to the net or listen to the radio or read publications that tell them about fibre, but they don't ask professionals where they get their fibre intake. So there's this extraordinary misunderstanding about where you're going to get fibre. I think the way to change that understanding is to teach the children, and they can then go home and teach their parents what to do. You can't have a high-fibre diet without a breakfast cereal. It's not possible, as Joanne said. And so grains and cereal fibres, we know they're the least consumed, about 10% in many studies. So I don't know what these children eat when they go to school. Presumably they go off, they might have a bar, an up and go or whatever, but they certainly don't sit down for 5 minutes and eat a bowl of cereal with their parents. So we think that if you can increase their fibre intake at breakfast, and there are some studies that show this, that the better performance of children during school if they eat a healthy, high-fibre breakfast. They're happier and listen more attentively to what the teacher says. So that if only 10% are eating a high-fibre cereal, you have a huge job to change that. So what we've done is to begin a clinical trial looking at the short-term effect of supplementing children with a fibre breakfast. And the objective is to build the evidence that Joanne has mentioned to show that improved cereal intake in fibre is going to be important for their digestive health. So we've modelled a questionnaire based on a US questionnaire, changed a few things to include Australian terms, and we've got 8 different questions to ask them. We might begin with, do you feel comfortable at passing the stool? And you've got a numerical chart between 0 and 10 to answer that. Or farting. I think every kid knows about that. And they can give an answer between 0 and 10. Women will say 1 or 2. Boys will say 10. And we didn't know how this chart was going to be received. So we had only a very small group of kids that we wanted to test the terminology and the methodology on. So they completed the questionnaire about their gut health. They used an evaluation form to tell us how good it was. And this pilot study included only 15 children between those ages of 8 and 12, which I think are the very formative years for changing their intake, because they can make their own decisions. So there were 6 males and 9 females, and almost all of them understood the questions. They found the scale easy to use. They didn't really need their parents to help them. And we've changed a bit of the terminology to make it more locally acceptable to Australian children. And when we showed that tiny group of children, the Bristol stool chart, which I think is a bit excessive, 2/3 of the children pointed to stools that are constipated rather than normal. So maybe we can't ask the children what they pass. We need to give them an objective diagram to say, tell us what you are doing, and that will help provide a better body of evidence about outcome. Because outcome is everything when you're going to talk about changing fibre. So we're now undertaking a randomised study in 120 children around the country, mainly in Sydney, between 8 and 12. They do a 14-day intervention. We give them a fibre breakfast to take each day. Get a little bag with their fibre breakfast in it to take home. It's a very nice bag. Pity we don't have some here. And we measure their digestive health outcomes at the beginning, after 1 week and 2 weeks. And hopefully we'll have, in the very near future, some outcome from that and be able to give you some more advice about where to go. But I think digestive health issues are common. They're probably more common than we all think. Many women and most children don't understand anything about fibre. As Joanne said, they eat a high-fibre diet because they have lettuce. And I think we do need to change the fibre intake of our children, but we need to demonstrate with outcome and intervention that that's what we can do. So I think you've all got a major problem on your little hands to help change the perception of where women and men are going to get their advice about recognising that fibre is more important than water in changing constipation. And I look forward to hearing from you in a couple of years. Thank you. Now, we're happy to take any questions.
Thank you very much. That was fascinating, both talks. I just had a question. I'm not sure I understand that you're still undertaking the study. If you could explain to us if, as well as providing the cereal, if you're measuring the fibre intakes of the children as well as the cereal? Are you undertaking nutritional analysis of the rest of their diet?
No. This is a preliminary study, so it's an intervention, seeing if giving them an extra 7 grams of fibre a day or thereabouts is going to make a difference. If it does work, then we need to do the study that you're suggesting.
Right. Thank you.
Joanne, what are the problems in the US about education of adults and children about fibre intake? Same as here?
Yeah, I think Australia has some real advantages because of just the grain. You know, it seems like cereal is more of a habit in the morning, that there's more cereal probably than there is in the U.S. And just some of the plant-based diets in Australia seems to be some advantages over the U.S. for probably average fiber intake being a little higher. I think that it's the same issue, though, that we have, is that in general we want people to eat fewer calories. And as we're telling people to eat fewer calories, fiber intakes go down. I mean, they just go down, so it makes it more difficult. It kind of adds to the problem. And I also think that for constipation, it is habits, just exercise, all these things that tend to be a problem too in more Western populations. So fiber for sure works. So I think that's one advantage, that if you look at the data, that if you give fiber, and we've been doing some studies with different fibers too. So for sure we know wheat bran works, oat bran works, all these kind of more insoluble fibers. But some of the novel fibers that are being added to foods, we actually have some data on soluble corn fiber, polydextrose, that there are other fibers that you can get into foods that actually increase stool weight too. So I think that the frustrating thing, I always say I've worked in fiber for more than 30 years. I've given so many fiber talks, and meanwhile fiber intake's gone down. So maybe I should not talk about fiber, because obviously what I'm doing is not working. But it just seems like that's a natural thing, because fiber intakes are linked to eating more. So. And that's why if we look at constipation too, it tends to be more in women, and food intake, the more people eat, the less likely they're going to be constipated.
I think it's true that women have certain beliefs about fibre. They believe it's going to put on weight, partly because that they might have milk with that, and that greatly influences their behaviour, I think. And I think unless the parent eats the same breakfast as their children, then the children are not going to learn too much. And I think if you want to give a child a breakfast cereal, you've got to take them to the supermarket and say, choose a high fibre cereal. You can't have those rice bubbles, but you can choose anything else. And then it's their choice, and it's their responsibility. Yeah.
Thanks, Prof. Bolin, for the great talk. I'm Hazrin from Malaysia. Just a quick question with your intervention trial. Do you take into consideration the children's physical activity level as well? No, with your intervention trial, do you take into consideration the physical activity level as well for the children?
Well, we won't measure that in the beginning, but I mean, this is one small step for man, as they say, and when we get the results of this, then we'll know how to proceed. I'd be optimistic that this intervention will show a change. And when it does, then we have to decide what else we do. Then we have to look at their fibre intake in general, their physical activity. That's much more difficult to measure. Michelle.
Yeah, can I just build as well, just in regards to the intervention study? We really wanted to do a study that was kind of free living. So in terms of the control around dietary intake and physical activity, which are all really, really important, we wanted to do something where we simply demonstrated changing breakfast and asking the children to keep everything else the same. And we've got a control group which are just doing their regular habits. If just something as simple as introducing a high fibre breakfast cereal would actually produce a difference in the children's reporting of their digestive health. So absolutely the studies that you've mentioned are important for that tight control, but from a very practical point of view, just asking children to eat a high fibre breakfast cereal that delivers 7 grams of fibre a day, we want to see if that can make a difference between the control group and intervention.
I'd just like to chime in here too that there really is a need for those types of studies, because so often people think, oh, okay, if we want to show that fibre works, let's get constipated kids and do a study, and it doesn't work. I mean, that's, first of all, those kids aren't, it's hard to get kids into a study like that, and when kids are constipated, that's, giving them just fibre and not dealing with any of the other issues isn't successful. So I think a study like this where you take regular kids that people would say, well, why not collect fecal samples? Because as soon as you collect fecal samples, that's a huge participant burden, and they're much less likely to participate. So I think the measures that they have set up are actually useful, because the kids actually get to describe digestive health symptoms and see whether there's improvement. So it'll be a great study to get published.
Yes.
Thank you both for your presentations. Terry, I just had another question on the study. The length of the study was 14 days. I was just wondering whether that would be enough to see changes in their digestive health.
I think it probably will. I don't deal with a lot of children. If you deal with adults and you change their fibre intake, you would expect to find a change in their stool size or discomfort within that period of time. So it happens fairly quickly, because the fibre has an effect very quickly on the bacteria in the gut, and that increases the volume of the stool. So it shouldn't take any longer than 14 days. And anything longer than 14 days is very difficult. Well, thank you all very much indeed for coming. I hope you enjoyed it.
I would like to put in a plug for you to fill out the evaluation. So if you would be nice enough, I think for Kellogg's to sponsor the breakfast to get out information on cereal fibre. Hopefully this is a useful format. So if you would take the time to fill out that evaluation, it would be great. I do want to mention, let me just follow up on that for the 14 days, because so often in designing clinical studies, it's difficult to do, but a lot of the prebiotic studies, if you look at how long does it take to change the gut microbiota, it's within 2 to 3 days you're going to show changes. Typically takes anywhere from 2 to 3 days to increase, get foods from what you consumed out. So I think 14 is a good compromise in being feasible, and still lots of time for fibre to, the gut to actually adapt to that increased fibre consumption.
It's been a great pleasure to have Joanne Slavin back with us. And Joanne, I hope it's not too long before we see you again.
Always happy to come to Australia. Appreciate it.
Thank you all very much indeed, and thank you very much to Kellogg's.